Dr. Kim gave a great talk, I think, about locum tenens, and some of that is actually, I think, related to this in terms of trauma. And of all the talks that I think I've been asked to give by the program committee, trauma and this talk is probably the most or the least clinical and the most reflective that I hope people sort of think about and think through as they sort of hear the presentation and hopefully see a few pictures along the way. As I go through and as you look at my disclosures, I'll tell you that, for me, my personal story is I'm actually not from Philadelphia. Philadelphia is my home. I'm from North Carolina, and I remember as I was growing up and I got through and I got inspired to go into urology, I said to myself, I really want to train in a big city. Philadelphia is now my home. I trained in Philadelphia. I went to Philadelphia, and I remember the very first week I was in the emergency room as a surgical intern. That's the guy who walked in or was wheeled in. That's the guy who was wheeled in. And the first thought I had was, why am I here? That was the first thought I had. But I will say, this patient is not the normal patient that's seen in a community setting. This is temple trauma. Temple trauma is really internationally recognized, and urology and general surgery and all the other specialties come together to take care of perhaps the sickest patients that present with traumatic injuries. Thankfully, for most of you that don't come from these types of urban type centers, you look at that patient and run in the other direction. And I promise you, I want to run in the other direction too when I see a patient like that. So, what is urotrauma? How important is it? Why is it that you, if you're in the community, should care about urotrauma? I'll try to convince you sort of in the next 15 to 20 minutes to try to care. There are just under 3 million people that are admitted with traumatic injuries in the United States. Less than 10% of them have GU organ involvement, and thankfully, most of them are non-operative. Most of them are non-operative. And I will say that because most of them are non-operative, we probably, let's say, pay less attention as we sort of evolve through our practice, because we know most of these injuries usually just get better. I recognize that. But my goal in the short talk is to convince you that urology training, as we reflect on it, really needs to evolve to give urotrauma more of a center stage. What exactly is urotrauma? A lot of it, I would say, is self-inflicted injury, right? Where you see people sort of, do crazy things that come into an emergency room, and you're like, what were you doing? Why were you doing that, right? And at the same time, the American Urologic Association, though, I think values trauma. They value it so much to create a urotrauma guideline. And they value it so much to then update those guidelines just 4 or 5 years ago. And let me say, if you ask the AUA, they'll say the answer is yes. We should care about trauma. Most urologists, though, trauma and or injury is the bane of their existence because most of that comes on call. And I think it's related to what Dr. Kim was saying in terms of locum tenens. Urotrauma, though, is all-encompassing. You look at all the organs that we are stewards of as urologists: the urethra, kidney, scrotum, polyorgan trauma, bladder, penis, and ultimately, iatrogenic injuries, I would say, are the injuries that are most overlooked by us, and perhaps the ones that most create a unique source of value for us as urologists. Here are guidelines that come from those urotrauma guidelines that I think directly affect all of us, right? Patients that have catheter-related injury or catheter-related trauma should be monitored for stricture formation. Whether we like it or not, we are seen as stewards of patients that ultimately have catheters, whether we're the ones placing them or the millions and billions that are placed by other specialists throughout healthcare systems. Emergency conditions like penile fracture, there's only a urologist that's managing that, right? No one else is managing that. And it is the bane of our existence to get called with penile fracture because we know that's going to need an operation. And sometimes that needs an operation, more urgently than sort of electively. So I guess I'm hopefully convincing you that we should care a little bit about trauma, but do we? All right, here's a series that I worked on earlier on in my career. It was maybe 10 years ago or so. And what we did was we queried program directors in the 2010s. We also queried program directors in the mid 2000s, and we asked, like, what is the exposure of trauma in your program? Dan Parker was a trainee when he did that. This guy is now an urologic oncologist in Oklahoma, right? And him and I sort of worked on this sort of assessment, and ultimately, program directors in GU training feel the volume of urotrauma you see today or back then was constant, and that it was a critical component of residency training. However, conservative management, like I just said, was felt to negatively impact interest and curricular development. Okay, ultimately, we've charted this all out. We compared sort of longitudinally from the 2000s to the 2010s. What does this mean? And ultimately, like I said, conservative management negatively impacted resident education and graduate preparedness. All right, so years later, this is David Hahn. I give him credit. He's chief resident right now at Columbia University, soon to be my next fellow starting in the summertime. Him and I had the question, well, you know, if you really do a meta-analysis and look through all of the education literature in trauma, how much do people actually care about this? So we went through sort of elaborate process, and we found that a third of trainees and program directors today feel that urotrauma exposure is lacking. Level 1 trauma centers are really supposed to enhance education, and I think they do. But ultimately, I think we tried to conclude that a standardized curriculum is necessary. So I asked the question, why should I care? Why should any of you care? I'm a big believer in the concept that, you know, we have to learn the lessons of our own history in order to avoid the failures of the past. And 20 years ago, where were we in urology? In urology, we thought we were the stewards of robotic surgery. I remember going through my training at that time, and it was a sexy topic to be a robotic urologist because very few centers were embracing robotics in any other field other than GU and maybe GYN. But let's look years later. Cardiac surgery, bariatrics, general surgery, ENT, GYN, colorectal, all these fields have now embraced robotic surgery. Where does that leave us? Are we now the stewards of robotic surgery? I don't know, are we? I would say that we are the stewards of robotic surgery, but there are plenty of other people now that have sort of weighed in on robotic surgery, and I think, you know, they have a stake to it too. It's a technology that I think has really benefited many patients in many scenarios and arguably benefited other patients in other scenarios. But this all comes down to a conversation over value. Dr. Kim said it earlier in his talk, there are numerous healthcare consulting companies that look at perceived value of specialties. Merritt Hawkins is one. You know, he had mentioned AMN Healthcare, that's another one. There's the ACS, there's American sort of College of Physicians, there's the AMA. Numerous organizations have tried to assess, are you valuable as a urologist? You know, we just heard data looking at locum tenens and the value of locum tenens. But I'll give you the quick secret. We're lucky. We just did great in our program, and urology did great in terms of recruiting great medical students to go into urology. Most people that pick urology, I think, pick it either because they were bothered by, or they had a family member that was really bothered by a disease or a disease process, or they were inspired by the people they met along the way, right? They really found someone along the way that really inspired them to go into urologist. But if you were to ask a healthcare consulting firm, is urology in your top 10 sort of most revenue generating, value driven fields? The answer is no. Urology is not in the top 10. Yet we have great people that go into urology. But from a system-based approach, it doesn't crack the top 10 of revenue-generating fields. What does? Cardiac surgery, bariatrics, orthopedics, some of these other fields. And so we right now have great people, and we're in a great forum of like-minded or similar-minded people that are inspired to be in urology. But I look at it as an analogy. If you're a healthcare administrator in America today, we are felt to be members of a large team, like any NFL team. Everyone has a role. And I'm hopeful that the team in red loses on Sunday. I'm hopeful the team in red loses on Sunday. And I'm also hopeful the guy who's kicking the ball misses. I'm hopeful he misses. But if we're a healthcare administrator in 2025, do you know where we are on this field? they think we are the holder. We are the holder. We're not the kicker, the guy who gets the glory at the end. And why is that? We have to generate our own intrinsic value. Who's counting the money? If you look over the past 30 to 40 years, there's been a 3,500% increase in physician administrators, not physicians. The number of physicians actually have only gone up by 100, 200%. So the people who are counting the money aren't the people in this room, and physicians are being outnumbered. And we're now talking about cost-conscious care, decreasing cost, increasing quality, and increasing experience. That's the language of the year 2025. And so today, I would say our ability to manage emergencies, catheter issues, intraoperative consultations is what generates an intrinsic value that makes us indispensable. You can't run a hospital without a urologist who embraces the above. And to Dr. Kim's lecture, that's why locum tenens is paid what they are paid. They are paid what they are paid because they embrace the emergencies. And the emergencies are under the domain of UroTrauma. Hence, respecting UroTrauma management truly increases our value. If you look, I know the slides are trying to come, I have some data that I can show you over where private practice urology is today. Urology practices are being acquired, exponentially by private equity firms. There's data here that really shows this, that you're either, by year 2030 going to be employed by a healthcare system, or you're going to be gobbled up by a private equity firm. And that's the future of our field. This is maybe several years old. These groups are still tops in the country in terms of how many urologists they employ, although those numbers have only gone up. And if you look at the complexities of care, health system corporations have physician companies, malpractice carriers, hospital companies, individual corporations, insurance plans, transport companies, and then for us, we even have a medical school affiliation. And you have to fit into this pie. And we're urologists. We're outnumbered. Like I said, we're outnumbered. And it's like a Fortune 500 company, a busy slide of an org chart. So I asked the question, how are you valued? In the end, our value in complex systems is most accounted for by our unique ability to handle GU emergencies. So as much as I don't like the concept of being a catheter jockey or a person who manages catheter issues or iatrogenic injuries for our partners and me who might get called in intraoperatively when GYN or colorectal has a problem, or the fact that we have to handle the rare surgical emergency like penile fracture. This is perhaps the most unique quality of what makes us urologists and what generates intrinsic value for us. No different than the locum tenens presentation that Dr. Kim gave as to why those people are getting paid, what they're getting paid, in the communities they're getting paid to do it, like Washington, where I now plan to convince my wife that we will move to. All right. So the value proposition for a healthcare administrator then is to look at the fields, represented. Dr. Bourgeon, who's not here, automatically goes dead last. Automatically goes dead last. But again, the service to the community of a BPH or kidney stone surgeon or a female pelvic reconstructionist is fantastic. But there continue to be sort of turf battles in who manages what, how they're managed, and how your value is perceived. And ultimately, the ability to create value or intrinsic value as an emergency urologist is what allows us for future career longevity. So, where does that leave us in terms of GURS? Right now I'm lucky to be sort of on the board of the GURS, and we've talked a lot about what this means for the field and what that means for us as urologists. Back when I was going through training, there were like 6 fellowships in GURS training, and now there are 30 fellowships in North America to become a trauma reconstructive urologist. And this is something that we worked on, with several other reconstructionists just recently, 1 or 2 years ago. And if you sort of longitudinally ask graduates in the past 10 years of GURS training, was your training worthwhile? Are you happy that you took on this field? The answer is yes. 95% of graduates are extremely happy that they went into the field of trauma reconstruction. And a large majority of academic programs today now employ a GURS surgeon, if not more than one. We have five. We have five GURS surgeons in our program, and that's fantastic. But that is the roadmap for solution for a curricular program. That is the roadmap. The fact that we now have GURS surgeons populated throughout, numerous healthcare systems, throughout academic centers. The idea is to then value case-based learning, value the importance of emergency coverage, expose our trainees to level 1 trauma centers, and build intrinsic value for urology. The idea of this wasn't to tell you to love trauma. The idea of this was for you to embrace it. So thank you, everyone. I really appreciate the opportunity. I'm happy to sort of talk to everyone later as well.